Yeah, good morning, ladies and gentlemen. Thank you, chairpersons. At the outset, I would like to thank GVK sir and the 3DCon team for having me here. When everyone is talking about SGLT2 inhibitor and metformin, I'm here to talk about where you should be careful or where you should be more careful, like avoiding some casualties as well. So we all know that we have been using these molecules, starting with metformin. Of course, we do see then and there, we do come across the patients who gets intolerant to these medications. The incident goes by 30% with metformin, and of course with SGLT2 inhibitors is 5 to 10%. Is it synonymous with allergy? No. So it's not synonymous with the allergy. Allergy is immune mediated. This is non-immune mediated, something which we would have seen. Lactose intolerance is the one thing which we all know and read a lot about that. So similar to that, when our patients are on these drugs, in fact these drugs are like life-saving drugs, that is crucial, particularly in the setup of a CVD or CKD, where these drugs might be of much useful to mitigate the progression of the disease. When the patient develops a intolerance, then the problem comes. Let us see how we can approach those patients. So we all know that this is the landscape of the medications which we use. Of course, the first line group of drugs or the metformin. Of course, there are certain group of patients, particularly patients are having a ASCVD. Then the treatment change. The first line of treatment is GLP-1 receptor agonist or SGLT2 inhibitor. Similarly, in patients with the CKD also, we have to use the SGLT2 inhibitor or GLP-1 receptor agonist as the first line of drugs. Of course, we do have a battery of drugs, starting with the DPP4 inhibitors, TCDs, sulfonylurea, and of course, insulins and GLP-1 receptor agonist as well. The third approach is to combine, combine all these drugs to achieve the glycemic target and also for the organ protection. But when a patient develops a intolerance, that matters many times because these drugs are guideline directed drugs which we use it as the first line agent in most of our patients. And of course, if we withdraw these drugs, definitely the patient is not protected in terms of the cardiovascular as well as the renal part of it. And we need to have a evidence-based alternative. Right now, we don't have an alternative. We have got some drugs. Suppose if the patient develops a intolerance to SGLT2 inhibitor, so we need to have an alternative, but there is no guideline-directed alternative. So that is another thing which we have. And it all depends on the patient subset also, which we need to remember. I'll start with the metformin. We all know that GI side effects are the common thing which we come across. It almost accounts for 30% of the cases, particularly in patients who are drug naive. When we start the patients with high doses of the metformin, usually our patients, they do tolerate up to 2.5 to 3 grams is the dosage, to up to 2.5 grams, many of our patients, they do tolerate. And they experience a lot of GI side effects in the form of nausea, vomiting, diarrhea, sometimes metallic state. Anorexia is also quite common in our patients, and usually it's dose dependent, which one needs to be aware. And the second one is B12 deficiency, as it minimizes the ileal B12 absorption. Sometimes with the duration of the intake is more, and with the dosage, sometimes our patients might experience a vitamin B12 deficiency. When the B12 is less than 200, you need to substitute, remember that, because diabetes and per se is a condition that can cause a neuropathy. This can, worsen it. The third thing is lactic acidosis, though it's quite theoretically it's rare, we don't see. So the type 2 lactic acidosis is the thing which we see with the metformin group of drugs. Usually we see in patients with wherever there is a reduced perfusion or hypoxia, where we could see these kind of lactic acidosis. In such situation, it's preferable to avoid the drugs. And of course, we all know that it's not a drug to be used in patients with the reduced eGFR of less than 30 ml. And other contraindications, of course, the renal thing, I'll brief you in my next slides. So before you switch metformin, first try to optimize this, whether the patient is having the real tolerance or not. That is the thing which we should look upon. So always talk with the patient and gradually, so how he experiences, start with reduce the dose and increase it gradually over a period of time. Preferably it should be taken with meal or immediately after the meal. And don't encourage the patient to be taken in empty stomach, because many times like it is combined with the sulfonylurea and the patient would be taking in empty stomach. So that is a problem which we see with FDC combinations. And always start low and slow and switch it to extended release. So that definitely like will help our patients to mitigate these GA symptoms. Of course, if necessary, we can add some prokinetics and antacids. Very simple therapy like that would enable us, our patients, to get rid of these things. Still the patient is continue to have these kind of GA intolerance, then consider about the next alternative. Of course, we do have the next alternative, starting with again SGLT2 inhibitors, GLP-1 receptor agonists, DPP4 inhibitor, TCDs. Of course, if we the glycemic target is achieving the glycemic target is the burden, like then we can go for the sulfonylurea, preferably extended release also. Of course, this is, we all know that like the dynamics of metformin in patients with the CKD, of course, a patient with the stage 2, so they can be given the full dose of metformin in patients with the 3A. So we need to reduce and watch for the complication, particularly in patients with 3A. So the lactic acidosis and those complications are quite common in patients with reduced eGFR. Please remember that. Like, so in 3B, you should, with caution, reduce the dose if possible, and go for alternative. And in patients with eGFR of 30, like better to stop. So coming again to the SGLT2 intolerance, we all know that like it's a drug with the various pleiotropic actions. So it was originally introduced as a drug to reduce the blood sugar, and later it was found a lot of the organ protective effects, and we have been using it in patients with the ASCVD, in patients with CKD, and the indications are growing every day, like MASLD. So every day we talk about SGLT2 inhibitor and add one new indications for these drugs. Of course, we do have the number of good drugs. Of course, we do have more noise with dapagliflozin and EMPA and ganagliflozin. So the problem which we come across in patients with SGLT2 inhibitor is the genital mycotic infection. So it's more common in women, and in men also it's common. In uncircumcised men, like it's quite common, like usually in the form of vulvovaginitis or balanitis. Usually they nicely respond to, because the why patients, so what are the 15 to 30% of the patients, they can have this thing in patients who are elderly women, patients who are having longer duration of the diabetes. The baseline diabetes is high, HbA1c is high. In such patients, like where these mycotic infections are quite commonly we do see, and of course the genital hygiene and a single dose of antifungal, preferably a fluconazole 150 milligram, definitely will improve and change the overall status of the thing. And it doesn't really warrant stopping in all the cases. Please remember that. So second one is like the urinary tract infections. Like if your patient gets, it makes a person at risk of developing a UTI. But if the patient develops a complicated UTI, so in the form of pyelonephritis, or if the patient is having a structural damage in the form of calculus or some anomaly or scarring, so already the patient has had a pyelonephritis. In such cases, you need to be very careful and preferably to reduce the dose. So the literature says that like the 10 milligram, say for example, if you use a dapagliflozin 10 milligram, definitely it make a person at risk of developing a UTI. But if you use the lesser dosage, 5 milligram, 2.5 milligram. We don't have any robust data with the 2.5 milligram. So, but the lower the dosage, the incidence of the UTI is less. So the exposure is also, it matters. Of course, somebody gets a recurrent pyelonephritis, it's contraindicated. You need to be very careful when you restart the patient on SGLT2 inhibitor, or if the patient has developed a phoneus gangrene, like again, it's absolute contraindication. So the third is the volume depletion hypotension. This is a quite common bothersome, particularly in elderly individuals. When you combine multiple drugs, particularly the diuretics, ACE, ARB, antihypertensive drug, like then it's a cause for concern, because we know that like SGLT2 inhibitor causes diuresis, natriuresis. So it can cause a little excess urine loss. So this can also make the patient jittery, having some giddiness and other things. Sometimes it can precipitate a already susceptible individual with multiple other core risk factor, like it can precipitate an individual to develop a AK also in some cases. The fourth one is the euglycemic decay. Again, you need to be very careful. Whenever the patient is unwell, while on SGLT2 inhibitor, please check ketones. So when the patient is unwell, please check ketones, because this is a little bit tricky. So we know that if somebody develops the typical DKA when the blood sugar is more than 250, here you never see such kind of a scenario. Always the blood sugar would be somewhere between 180 to 250, and it may deceive you, it may cheat you. So you need to be aware of this condition, euglycemic condition, particularly when the patient is concomitantly having a stressful situation, going for a surgery or going for some kind of any viral infection. You need to be very careful where it can precipitate into a euglycemic decay. Of course, the lower limb amputation, there are some minor incidents where the metatarsal amputations were seen with canagliflozin. We all know that. So how do we manage these cases with gentle mycosis? As I already alluded to, a single dose of fluconazole and genital hygiene is the key. And if a patient is having an uncomplicated UTI, still we can continue the thing. Maybe preferably we can advise on the personal hygiene and control of the other risk factor, glycemic targets, HbA1c, of course the genital hygiene part of it. Polyuria and frequency is quite common. So recently I happened to have one of the manager, the pharma company manager, who was put on SGLT2 inhibitor. The moment he started taking, he developed a polyuria. So that is increased frequency of urine in the daytime, not only in the nighttime, so in the daytime. So he had to go to restroom almost to 20-25 times. He was a bit restless. I had to reduce the dosage. He was here in the stalls now. So that's a very common situation. You need to advise the patient, because over a period of time, the symptom also will come down, and volume depletion, particularly when the patient is having a compromised cardiovascular hemodynamic status, euglycemic decay is another thing which you need to be aware. And true intolerance is quite rare in patients with SGLT2 inhibitors. So of course, we do have the alternatives like GLP-1 receptor agonists, particularly when they have any organ dysfunction. So switching strategy when the patient is having a heart failure with patients who are already on SGLT2 inhibitors and they are subsequently found to be intolerant, we can go ahead with the GLP-1 receptor agonist. Of course, the DPP-4 inhibitors is not much evidence with regard to the ASCVD, but you need to be very careful with the Saxa because it can precipitate a heart failure also. And with CKD, the metformin is stopped, then we can go ahead with the SGLT2 inhibitor, GLP-1 receptor agonist, or the other two good drugs which are available to mitigate the progression of the CKD. If the patient is obese and intolerable to both the drugs, we can go ahead with the GLP-1 receptors. Of course, we have heard a lot about these GLP-1 receptor for the past 2 days and its beneficial effect in reducing the body weight. So recurrent UTI and gentle mycosis, again, if the patient is in a complicated situation, developed a complicated unit tract infection, then we can go ahead with the GLP-1 receptor agonist. So that's a good drug. With patients with NASH, still TCDs are a good drug, that can reverse the histology of the fibrosis part of it to a certain extent. So that seems to be a good alternative along with the GLP-1 receptor agonist. So these are all the GLP-1 receptor agonists which are available. We all know that we have been using and we have been listening to various speakers talking on these drugs in detail. So this is my final slide. So I go with the summary. So when the patient develops a intolerance to SGLT2 inhibitor and metformin with obesity, we can go ahead with GLP-1 receptor agonist. Of course, we do have the dual agonist tirzepatide also. If the patient is intolerable, but patient is elderly patients, the replacement is little bit challenging. Of course, the GLP-1 receptor agonist, the patient could afford, or if the patient is having any organ involvement, or we can go with gel it with the DPP-4 inhibitor. These drugs are quite safe in patients with the elderly. And if the patients are intolerable and having CKD, the other options what we have right now with us is, again, we can go with GLP-1 receptor agonist. So with this, I end my talk and I'm happy to take some questions. Thank you.